Hi, welcome back. I'm Dr. Carl. Today we're going to continue talking about paracetamol overdose. We're going to look at some good examples of pearls and pitfalls when it comes to managing cases, and we're going to also consider what to do in cases of massive overdose. Let's get started. Alfie is a 23-year-old bodybuilder. He's brought to A&E by ambulance, drowsy, nauseated and vomiting. His friend tells you he took 10 500mg tablets with alcohol last night, but is not sure when. Here we have an inability to establish the time of ingestion. On further history, the friend suggests that it may have been in the last 2 to 6 hours. As a result, the decision is taken to measure the paracetamol concentration and AST. If either is elevated, the plan is to treat with NAC. The rationale for this plan is based on 3 principles. NAC is not without complications. Benefits should outweigh harm. However, if any AST elevation is present, it indicates hepatotoxicity and warrants treatment. Also in this context, any measurable paracetamol suggests greater risk and impending toxicity, again warranting treatment. Next, we have Belka. She admits to taking extended release paracetamol, not widely available in the UK. The amount taken was 5 grams about 4 hours ago. Her measured paracetamol level is below the treatment line when measured at 4 hours. Should she be discharged? In short, no. Whilst the nomogram still applies for deciding treatment as per any other acute paracetamol overdose, in this circumstance there is the potential for a delayed peak, and the second paracetamol level should be measured at 8 hours since the ingestion. Indeed, this is the reason extended release paracetamol has largely been discontinued. Extended release or not, delayed peaks and nomogram crossing is thought to occur in up to 10% of all acute paracetamol ingestions, and so a second paracetamol level should always be considered. Chandru is your next patient. He has come to hospital with fever and feeling unwell. As you clerk him, besides noting diabetes, chronic neuropathic pain and arthritis, you take a medication history. You quickly learn he has been taking 6 cocodamol, 8 paracetamol and several Neuromol tablets daily, in addition to Lemsip for pain and flu symptoms. Today he has right upper quadrant pain and feels much worse. What are you worried about? Yes, there is a worrying chance of accidental chronic paracetamol overdose from paracetamol in multiple drug preparations. Evidence suggests that 4 grams a day or less is safe. Some studies suggest probably 6 to 8 grams can be safe, but this is not proven. Case reports, however, demonstrate retrospectively that many patients like Chandru with hepatotoxicity have only had mild supratherapeutic dosing. As such, cases of chronic overdose, such as in this case, are worrying, very worrying. Overall, robust research is lacking. Nonetheless, what is certain, Chandru's medical history makes him high risk. Any total daily ingestion greater than 200 milligrams per kilo is high risk. As such, Chandru should be treated with NAC immediately, pending further results. Your next patient has come from maternity triage. At 34 weeks pregnant, she is in tears admitting to taking an overdose. At booking in, her weight is 80 kilograms. She is previously healthy. She is desperately worried for herself and her baby. Unfortunately, paracetamol does cross the placenta. A fetal liver can produce NAPQI from paracetamol from as early as 18 weeks gestation. As such, regardless of the mother's ability to metabolize paracetamol safely, a pregnancy is at high risk from hepatotoxicity at and beyond this stage, if not sooner. There should always be a low threshold for NAC, even in this setting. Whilst again research is lacking, any paracetamol level above the treatment line warrants urgent treatment with NAC. Happily, there are no case reports of fetal or maternal toxicity in women with paracetamol concentrations below the treatment line. So if this is the case, it can be taken as reassuring. Lastly, when calculating the NAC dose, given pregnant physiology, the patient's current weight should still be used, up to a maximum of 110 kilograms. Now we have Harry, sent to you by his GP. He has admitted to taking all the paracetamol tablets in a blister pack, alongside alcohol. Do we need to treat him differently? It's a single ingestion, and it occurred about 4 hours ago. If we remember that the paracetamol protocol was based on patients with chronic alcohol use, we can remember that we can confidently manage him in the same way as the standard protocol. That is to say, we can make our treatment decision based on his paracetamol level after his single overdose. Whilst his liver baseline condition in theory is worse, this recommendation still holds true. In all these cases, we have referenced action in relation to paracetamol levels and/or liver enzyme tests. Let's think about these blood tests a little more. In an undifferentiated patient with unexplained metabolic acidosis or deranged LFTs, paracetamol as a hidden cause should always be considered. Think about measuring a paracetamol level in these patients as well as those who have admitted to a paracetamol overdose. Secondly, do not be reassured by normal liver function tests and/or a normal blood gas in the first 12 hours following an overdose of paracetamol, as these can be falsely reassuring. After 12 to 24 hours, normal blood tests are reassuring, though any elevation in liver enzymes in this time carries a very poor prognosis and should be taken seriously. AST can rise earlier than ALT, and so measure this, as it can also provide an early clue of hepatotoxicity. Lastly, INR. It does not always rise in the early stages. It is typically under 2 in the first 24 to 72 hours. After this, the INR may begin to rise in cases of liver damage, and so an INR above 3 tends to occur only after day 3. These points are summarized here. Thus far, we have not discussed activated charcoal. So when can we and should we be using it? Strictly, the indication for activated charcoal is in cases of paracetamol ingestion that are greater than 150 milligrams per kilo. If being used, it should really be used in the first hour after ingestion. However, it can still have a benefit in the cooperative patient even after an hour has passed, especially in cases where delayed absorption is suspected or in cases of massive overdose. A dose of 50 to 100 grams or 1 gram per kilo activated charcoal can be swallowed, but more typically is given via NG tube. If more than 500 milligrams per kilo of paracetamol have been ingested, or more than 30 grams of paracetamol have been taken, we can describe the overdose as being massive. Here, the paracetamol level is likely to be several times higher than the treatment threshold. Here, early coma and a marked lactic acidosis are possible from the onset. We need to consider all treatment options to give this person a chance at survival. Of course, NAC should be started as soon as possible. Consult a toxicologist as they may suggest altered dosing, though avoid delay and begin your standard protocol whilst having these conversations. As discussed, activated charcoal can reduce paracetamol absorption and can bring benefit for up to 4 hours post massive ingestion. Discuss dialysis early in cases of altered consciousness, metabolic acidosis, raised lactate, and or cases where paracetamol levels exceed 900 milligrams per litre. Lastly, in the United States, famipizole has been studied as it halts the formation of NAPQI. However, at this time there is insufficient evidence to recommend its use. Is that everything? Not quite. Speak to an expert. In our case, firstly, this may be your local poisoning centre, certainly if any of the following are true. In all and any cases of very large or massive overdose, if the paracetamol concentration is more than triple the treatment line, in all and any cases of intravenous paracetamol overdose or error, in cases where ALT is greater than 1,000 international units per litre, and in any cases of neonatal paracetamol poisoning. A further phone call may be that for concerns of liver failure. Discuss with your local liver centre if any of the following are true. Any suggestion of liver failure as indicated by a raised INR or symptoms of encephalopathy. Any suggestion of renal failure if reduced urine output or raised creatinine. And in any cases of low blood sugar or severely low platelets, the liver centre should be called. If you're struggling with dosing NAC, get a pharmacist. NAC dosing errors can lead to a cerebral edema, seizure, and or anaphylaxis in as many as 8% of cases. Clearly, intensive care should also be notified if there has been any ABC concerns, such as persistent hypotension. Lastly, liver transplant as a last resort should not be a last-minute consideration. Factor this into discussions, especially in cases of hyperphosphatemia. A high phosphate suggests extensive hepatocyte necrosis and is a poor prognostic indicator. In pediatric cases, all children and young people require an assessment by CAMS following an intentional overdose, as stated in the NICE guidance, self-harm, assessment, management and prevention of recurrence. Of course, in both pediatric and adult contexts, respective safeguarding concerns should also be considered. Here is a summary of the pearls and pitfalls from my 2 talks. taken kindly from EM cases. For further learning, consider looking at guidance from the BMJ, from the Royal College of Emergency Medicine on paracetamol overdose, and listening to the podcast episode 180 from Emergency Medicine Cases, as well as further resources as part of the British Liver Trust's website. Thank you so much for listening, and remember, when dealing with a paracetamol overdose, things are not always as they appear. Take care to avoid the pitfalls. Thank you for joining us for today's video. Do consider subscribing for further content to support this channel. Many thanks from Dr. Carl.